Dear friends of HTAi, welcome to the first plenary of our annual meeting. My name is Meindert Boysen. I'm the Director for Health Technology Evaluation at NICE, the National Institute for Health and Care Excellence in England. As you know, we're co-hosting this conference with our colleagues in Scotland and Wales, and we're delighted that you're all here, gathered in the various countries across the world, listening to our first plenary. It's a great pleasure and honor to moderate this session with Hao, who has become a great friend over the past months when we together collaborated on our work to overcome some of the COVID challenges. And June Rain already spoke about that work, the work around rapid C19. These are challenging and at the same time very exciting times. COVID has put a spotlight on the need for innovation in technology, innovation in the way we work together, innovations in the methods that we apply, and innovation in the way we invite patients, carers, and service users into our world. HTAi is all about that, bringing others around the table, which is why innovation through HTAi is such an all-inspiring title for this conference. We heard this morning from June Rain how important partnership is and collaboration in deriving innovation. Such partnership extends well beyond the regulatory HTAi interface as a key component of the life sciences ecosystem into the guidelines and evidence ecosystems. At NICE, we're in a unique position to bring these two ecosystems together. Like gears in a complex machine, we oil them with our staff and our committees. We recognize the rapid pace of innovation in health technologies, the digital data and real-world evidence revolution, the removal of traditional service delivery barriers, the increasing collaboration post-COVID and in our case, post-EU exit, the increased focus on health inequalities, and last but not least, the economic challenges. In our 5-year strategy, we bring all this together in 4 pillars of work around rapid, robust, and responsive HTAi, dynamic living guidelines, and research and real-world evidence. These 2 other ecosystems, the guidelines and the evidence ecosystem, are vital in ensuring that HTAi continues to make the difference for patients, the health service, and industry. COVID has been a change agent for our guidelines program, from a rather static, slow, and singular approach to now a very much dynamic, collaborative, and a living guideline program for learning healthcare systems. HTAi will have to make a similar move from health technology assessment to health technology management. We can only do that by taking a different perspective on the evidence and its use, its relevance and contribution. This is where new trial designs come in, as does real-world evidence, and managed access and managed entry agreements, already mentioned this weekend. This will be ever more important when we think about new technology, new devices, diagnostics, and digital. Today's plenary will set the scene of why and how the current evidence ecosystem is evolving and adapting in the changing needs of decision-making. We'll be showcasing how evidence generation can balance rigor with speed. We'll be learning from the efforts of clinical guidelines developers to respond to health system needs. And finally, we'll be hearing about developments within HTAi to embrace these methodological advances. Let me hand over to Hao, who will introduce our speakers and how we will be running the session. I hope you enjoy it. Thanks very much.
Well, thank you very much, Meindert, and hello everyone, and welcome to this session. I'm Howell Williams, and I work for our National Institute for Health Research. And as Meindert says, we've been working very closely with the MHRA and NICE and NHS England to really look at research oversight and getting treatments to our patients as quickly as possible, breaking down many, many barriers, and what a pleasure that has been. So I'm sorry that Philippe Raveau, who was meant to be convening or chairing this session, is not able to be with us, but I did have the pleasure of working with Philippe on a series of 3 seminal papers published in the Journal of Clinical Epidemiology last year. But even though they were published in July, we were working on those papers in June 2019, long before the pandemic broke out. And I was mainly contributing as a funder because I was directing the Health Technology Assessment Programme of the UK at the time. So the first paper was called Evidence Synthesis Ecosystem Needs Dramatic Change. And the first draft of that paper, Philippe had put down, it needs a cataclysmic change. And well, I think, I'm not sure if it was me or the editors, but I said, oh, you can't say that, Philippe, you can't say cataclysmic. And it got diluted then to needs dramatic change. But that's spooky because it was a cataclysmic change that effected the changes. So the first paper was about what's wrong with the current evidence synthesis system, not properly addressing stakeholders' needs, erratic, insufficient interaction, particularly between primary research producers and systematic reviewers. That's impeding optimal use of data. The second paper, then, we described the ways in which the diverse use of data, different sorts of data, has broadened for systematic reviews. And we thought of this evidence synthesis ecosystem that conceptualizes evidence synthesis as a continuous process built around a clinical question, rather than a small team independently answering a specific clinical question at a single point in time. And then the third paper was putting it all together as a new evidence ecosystem. And that's why it's so relevant to this particular session, not just focusing on synthesis, but bridging the gaps between primary researchers, guideline developers, health technology assessment agencies, and health policy authorities. And by encouraging communities to work together continuously with bi-directional interactions, it requires greater incentives and rewards and involvement of healthcare policy. So I can tell you honestly, having been a clinical researcher myself for the last 20 years, I have been a player in a relatively disconnected evidence production system. There are some advantages in it, but I'd work for 2 years building up a proposal to get funding for a national clinical trial. I'd then take 5 years to deliver that single question clinical trial. I'd then get it published in the Lancet, and then I would fall in a heap. Or I would participate in a Cochrane review, taking 3 years, and then fall into a heap and look to all sorts of excuses to avoid the pain of starting again 4 years later for an update. Then the relevant NICE guidance team would work incredibly hard in an asynchronous fashion to produce guidelines. They would maybe miss my study, and they might fall into a heap at the end of it and contemplate not updating the guidance until there's a large bucket of new practice-changing evidence. So it's quite spooky in a way that our vision, or the vision of Philippe and our international collaborators, I don't think that cataclysmic change would have occurred without this system shock that the pandemic has made us do. I mean, let's face it, we can't work at home, we can't do virtual meetings, but we can. And that's what the cataclysmic shock has enabled us to do. The challenge now, of course, is how to learn, sustain, and build on that rapid change going forward, especially this balance between speed and rigor. So to do that, we're going to hear from 3 esteemed colleagues whom I would like to introduce briefly. Now, the first is Professor Sir Martin Landray, and I'm really sorry to tell you that literally half an hour ago, Martin has emailed us to say he's had an urgent family illness to deal with. So I'm afraid Martin won't be here for the live panel discussion. But we do have his pre-recorded talk. So I'll just tell you a little bit more about Martin. So Martin is Professor of Medicine and Epidemiology at the University of Oxford, and he leads the Clinical Trials Programme for Health Data Research UK and NHS DigiTrials, the National Data Hub for Clinical Trials. He's co-chief investigator of the Recovery Trial, which I'm sure you've heard of, which is a national priority platform trial of potential treatments for patients hospitalised with COVID-19 in the UK. And Martin is also quite heavily involved in international efforts to streamline guidelines and regulations that govern clinical trial conduct. The next speaker will be Professor Anna Gagliardi. Anna is a senior scientist at the Toronto General Hospital Research Institute. Anna's research focuses on guideline implementation, person-centered care for women across the lifespan, and policies to optimize medical device safety. And she largely uses evidence synthesis, qualitative methods, and consensus techniques. Anna is currently chair of the Guidelines International Network's Implementation Working Group and a member of committees that promote equity and diversity in research and uses the DORA principles in performance review of researchers. And then finally, we have Professor Tracy Merlin. Now, Tracy is a methodologist, an epidemiologist, and head of the School of Public Health at the University of Adelaide. She's currently chair of the International Network of Agencies for Health Technology Assessment. Anna is director and founder of Adelaide Health Technology Assessment, which is a large and respected HTAi agency that was established back in 2001. And she's been responsible for developing guidance for the Australian Pharmaceutical Benefits Advisory Committee, as well as to Medical Services Advisory Committee for public funding decisions. So during these talks, now please use the discussion forum. I see some chat going on there, interactions between yourselves, say hello, tell us what you're thinking. We would love to hear from you. And if you want to ask a question or raise a comment, with the panel during the live session, the live Q, use the live Q&A session, and Minded and myself will be looking at that as the talks go ahead. So now we're going to hear from the three pre-recorded short 12-minute talks from our three esteemed speakers, to be followed by a live panel discussion.
My name is Martin Landray, and it's a great pleasure to talk to you today about the Recovery Trial, the world's largest trial of possible treatments for patients hospitalised with COVID. Now, if I take you back to the beginning of last year, we were facing an unprecedented clinical challenge, an overstretched health service, huge time pressures and personal stress for frontline medical staff, and large numbers of unwell, anxious and often elderly patients. And of course, they were always alone because of the social distancing and infection control measures. And yet, what did we know about COVID in February of last year? Well, we knew it was going to be a major public health crisis for patients hospitalised with COVID. Then sadly, 1 in 4 would not survive that hospital admission, and the situation was even worse for ventilated patients. There was huge uncertainty about possible treatments, with many candidate drugs, many opinions from many sources, some qualified, some not, some with extraordinarily loud and prominent platforms. There was no reliable data, some uncontrolled case series, inconclusive small randomised trials, much opinion-based medicine, many papers being published even in leading medical journals that were unreliable and inconclusive. And what we felt was that it was unlikely to be a single big win, but it was much more likely that there would be modest benefits from a number of treatments. And if, just like HIV and heart disease and diabetes and cancer, we could find a number of treatments which could be used widely and used in combination, that could have a very big impact on outcomes for patients. But to find those treatments requires large-scale randomization, and we had to do that in the face of this pandemic. So we had to keep things simple, and actually that's a good mantra for many of us all of the time. Simple eligibility. The question is, how do we treat patients who've been hospitalized with suspected COVID? So that was the eligibility criterion. The outcomes had to be the ones we cared about: mortality, use of a ventilator, duration of hospital stay. Of course, randomized, non-randomized studies just give uninformative and unreliable information. And it had to be practical. A simple one-page case report form, one at the beginning when patients were enrolled, one at the end at 28 days, and a one-page consent form focused on informing the patient as opposed to overburdening them with information. And patients who were admitted to hospital who had proven or suspected COVID were randomised and would receive either an active treatment such as lopinavir or dexamethasone, or no additional treatment. So there's a control arm. Of course, everybody receives the best care that the NHS could offer at the time that they were enrolled. And over time, that care has changed, partly as a response of the results from recovery itself. The outcomes that matter: 28-day mortality, and as I say, hospitalisation or the need for a mechanical ventilator. And of course, we're able to enhance that with the health service data that sits all around us. 25 different data sets covering hospitalizations, for example, the hospital episode statistics held by NHS Digital, mortality data, for example, from civil registration data, which are held by the Office for National Statistics, disease-specific data sets from renal registry, primary care data, critical care data, and data that's told us about laboratory testing for coronavirus. All of these data sets could give us information both about the types of patients and about what happened to them. And we had to move fast. We wrote the first protocol on the 10th of March. By the 19th of March, the first patient had been enrolled, having been through ethics approval and MHRA approval and so on. And by the 3rd of April, 1,000 patients had been enrolled. In fact, 8 weeks after enrolling the first patient, 10,000 patients had been enrolled, and 100 days later, what we had was the first results, as I'll come on to. Now, COVID can affect anyone, and so recovery is open to everyone, regardless of location, from the Western Isles of Scotland to Truro in Cornwall, from Northern Ireland across to Norfolk and East Anglia. The trial was efficient. At its peak in Easter of 2020, over 400 patients were being enrolled in the trial each and every day. There was then a lull over the summer, which was a relief for us all, but of course, as we know, a resurgence in the autumn and then in the winter. And in January of this year, recruitment hit its peak, and at one point, 1,000 patients were enrolled into the study in 30 hours. This is how one generates robust information, high quality information, but does it at scale and at speed. And so over the course of that time, we now have randomized a total of 40,000 patients into the trial. As I say, every single hospital in the country is taking part. And what we can see is that across those hospitals, on average, 1 in 10 of all patients who've been admitted with COVID over the course of the past year have been enrolled in the study. In this chart, on the blue bars, this chart happens to be a snapshot of the situation in October and November last year. The blue bars are acute hospital trusts. You can see that some are busier than others, admitted more cases than others, and the orange dots are the proportion of patients at those trusts that are entered into the study. And you can see that while the average might be 10%, there are some that are recruiting, say, 25% or even 35% of all their patients into the trial. What about the answers? Well, the first is that many of the treatments that people thought would work do not work. So each of these treatments on this slide has been widely recommended, loudly promoted, widely used, and yet each is useless in the context of a patient who's been hospitalized with COVID. Hydroxychloroquine, a miracle drug according to several presidents and a number of senior academics. Lopinavir, which was with hydroxychloroquine first and second choice on many national and international clinical guidelines in spring 2020. Azithromycin, an antibiotic thought to have some anti-inflammatory properties which might be useful against this virus. It turns out that the antibiotic should be kept for fighting bacterial infection. It does not reduce mortality in patients with COVID. Convalescent plasma, over 100,000 people in a non-randomized study in the United States. No control arm, no randomization, no idea whether the treatment works or not in that context, and indeed over 500,000 Americans have received convalescent plasma over the course of the last year. It turns out that for patients who are admitted to hospital, when you do the randomised trial, you find that there's no meaningful benefit of convalescent plasma. These results are important because they allow us to move on. We can stop wasting resources. We can stop exposing patients to treatments that don't work. We can stop making false promises to patients that these treatments might work. But of course, what we're all looking for is treatments that are beneficial. And the first of those came on the 16th of June last year, and that was dexamethasone. So a simple, if you like, cheap and cheerful steroid drug that's been around for decades is in every hospital pharmacy, in pretty much every hospital, in pretty much every country in the world. It turns out that for the sickest patients, those on a mechanical ventilator, it reduces mortality by a third, and for other patients, for example, those requiring oxygen or other forms of ventilation, it reduces mortality by a fifth. That result was announced at lunchtime on the 16th of June last year. By tea time, the chief medical officers had written to every hospital saying that this should really be practice. And by the weekend, it was saving lives. Within days, within weeks, it was being used all around the world, and the estimates are that it saved in the order of 1 million lives over the course of the subsequent year. I don't know whether that estimate is right or not, but I think it would be I would feel confident saying it's at least 500,000 lives saved from this one simple treatment, which many people thought should be contraindicated, should not be used, should not even be studied this time last year. Tocilizumab, a treatment for rheumatoid arthritis, an interleukin-6 antagonist, used very widely in northern Italy in the outbreak of February 2020, but nobody knew whether it was any good or not because it wasn't studied. There were some small-scale studies during the last summer, all of which were inconclusive, and then you do the big, large randomized trial and you get clear answers that tocilizumab on top of steroids reduces mortality by a further 14 or 15%. And then just this past week, a new treatment, the monoclonal antibody combination, in this case produced by Regeneron, which binds to the spike protein on the outside of the virus. And what we demonstrated was that amongst patients who are, as we would say, seronegative, in other words, they haven't raised antibodies of their own, mortality is reduced from 30% to 24%, an absolute risk reduction of 6 lives saved for every 100 patients treated, a proportional risk reduction of about a fifth. What's so interesting is that these are the higher risk patients who've already raised antibodies of their own are up to about half the level of risk, and they do not benefit from being given further antibodies in the form of a monoclonal cocktail. So this is a good example, if you like, of precision medicine, really demonstrating that if you can give monoclonal antibodies to patients who haven't got antibodies of their own, you will save lives. So what have we learned from all that? Well, what we've learned, I think, is that randomized trials are an essential component of high quality clinical care. Arbitrary use of unproven treatments is damaging to patient care. I would argue it's damaging to patient trust, and it's damaging to public health and resources. We have to make sure that randomized trials are a component of clinical care, and we have to think very carefully about any barriers we might put in the way. Why is it harder so often to randomize patients in a clinical trial than to give them the same unproven treatment as part of open practice? That needs to change. The second thing I would say is that I think that decisions, whether one's making guideline decisions, payer decisions, commissioning decisions, regulatory licensing decisions are so much easier when you have compelling results. Randomized trials of sufficient scale give you that compelling information. They make those decisions easy. They have impact. But trials must be designed well. They must be feasible for patients and clinical staff. They need to be inclusive of the relevant patient groups, and they need to be focused on the outcomes that matter. So often we get confused and distracted, and we overburden clinical trials with things that might just be interesting or just in case. Let's focus on what matters, get a clear answer. Now, this requires leadership and coordination and collaboration and fairness and transparency. Transparency, particularly with patients and the public. Everything I've showed you here is on the online website. Every version of the protocol, every version of an ethics submission, all on the online website. And these lessons are important not just for COVID, but also for tackling the burden of many other common diseases. Finally, enormous thanks, of course, to the funders and our collaborators, to the doctors and nurses who've contributed at such difficult times, but most importantly, to the 40,000 patients who've participated in this most extraordinary project. The future treatment of patients with COVID is better because of the clear results from trials like Recovery, and those trials would only be possible with the participation of those patients. We're extraordinarily grateful. Thank you.
I'm really pleased to have been invited to speak with you about innovations and efficiencies in guideline development. Just a bit of background about myself. I am a health services researcher with a focus on implementation science. Throughout my career, I focused on guideline implementation, and more recently that has expanded to include implementation of patient engagement and patient-centered care, particularly for women with a variety of health concerns across the lifespan. And I collaborate quite widely on what I will call quality improvement and patient safety research. I was asked to speak with you in order to share innovative guideline development approaches. And throughout this presentation, I'll be touching upon the use of various forms of evidence, adapting guidelines to context of different settings, rapid processes of guideline development, creating and updating living guidelines, and responding to emergencies. There are a lot of similarities between clinical practice guidelines and health technology assessment. If you're not aware of it, the Guidelines International Network is a nonprofit organization that includes guideline developers and implementers from around the world. And GIN, as it's known by acronym, has a number of different working groups. One of them is the GIN HTAi working group. And that particular group explores similarities and in terms of aims and methods, and aims to share products between GIN and the HTAi community. Because of those similarities, I was asked to speak on this topic. And in particular, something that guideline developers and developers of health technology assessments share is the fact that the processes require considerable infrastructure, resources, and time, which is why I was asked to share some of these innovative processes from the guideline world in case they are of use and relevance to those developing health technology assessment. So I'll just pre-warn you that in my presentation, I will be sharing with you a lot of different resources so that you may be able to refer to them later. I'm not involved in any of these initiatives, but as someone from the guideline community and a member of the Guidelines International Network, I'm familiar with these very interesting projects that are taking place. First, let's talk about different forms of evidence. I wanted to make you aware of this particular GIN working group. They are a relatively new group and just getting going. Their acronym is AID, which stands for Appraising and Including Different Knowledge in Guideline Development. And their specific purpose is to identify methods and share those methods for including a wider range of knowledge sources in guidelines. They're just about to publish their first paper, which will introduce this topic, and I wanted you to be aware of them and look for their upcoming work. Additional resources throughout this presentation will have been generated by the GRADE group. And in case you're not familiar with this group, they are based at McMaster University, but essentially they are a worldwide network that has created a lot of processes and tools and guidance to support guideline development. And they published this study on what to do when there is no evidence. And they refer to what they call collective expert evidence or experiential evidence. So when there is little or no evidence, what they do is survey guideline development panelists, and from them, they collect information on experiences or cases of having used different treatments. And then that information is collated, shared with the guideline development panelists in an anonymized fashion to inform the formulation of recommendations. So while it's not exactly retrospective administrative data, it's a step above expert judgment. A group of primary care clinicians in Canada recognized that there was a need to develop a process for developing guidelines when evidence is conflicting. So they developed a process for what they called simplified guidelines. Their view is that in those circumstances, guidelines should support shared decision-making between patients and providers without attempting to recommend for or against particular clinical processes. And so they've developed a process which involves a larger proportion of community providers and patient input versus what they call experts. And they developed an algorithm format for their guidelines, and their guidelines are also accompanied by a lot of practical tips and tools. And here what I show is the 3 guidelines that they've developed in this manner: lipid management, medical cannabinoids, and managing opioid use disorder in primary care. More and more guideline developers are using qualitative evidence, and I've chosen 2 such studies to share with you. The first one is a content analysis of 64 guidelines in which qualitative evidence was used. The authors found that qualitative evidence was used in 3 primary ways to identify guideline questions and enablers and barriers of implementation. They also identified some limitations. For example, in all instances, no qualitative experts were members of the guideline development group, and in most cases, qualitative evidence was not appraised in some manner. To build on those methods, the second study I'm showing you in this slide was based on 3 case studies of World Health Organization guidelines. And in particular, this study focused on mixed methods. So they drew from mixed methods research to provide a lot of useful guidance on whether and how to consider quantitative and qualitative evidence separately, or whether and how to integrate it to formulate or inform recommendations. Adapting guidelines is another area receiving a lot of attention in the guideline world. This recognizes that there are a lot of existing guidelines, and that rather than developing guidelines de novo, it might be more efficient to adopt or adapt existing guidelines. I know this is not a very good slide, but again, I'm trying to share with you a lot of information that you can take away and potentially use later. So this particular publication was developed by GRADE, and it's for a process they call adolopment. It is in part a decision-making tool and in part a process for adapting guidelines. And so the process is that once questions are formulated and a search is conducted for guidelines or systematic reviews on that topic, if none of that evidence answers the questions, that means that a new guideline must be developed. However, if guidelines or syntheses are available, then one would go down the algorithm you see on the left-hand side of the figure, If the evidence is closely matching the context within which the guideline is being developed, then those recommendations could be adopted. If instead there are some differences in the local setting which must be considered, then the evidence or the recommendations would be adapted. Now, adolpment is just one process or tool that has been developed to support guideline adaptation. Another one is called ADAPT, A-D-A-P-T-E. And it was initially used for a study in which they were adapting clinical practice guidelines on osteoporosis for use in Mexico. So they started with ADAPT. They found that it was a little bit too complex. They switched to using the grade adolpment process, and they supplemented that with the RAND UCLA consensus approach. The second study I'm showing you here was based in Saudi Arabia, where they further simplified the ADAPT process in order to develop 2 or 3 guidelines. And this particular paper has a very nice table in it which shows the modification to the ADAPT process. So there's a variety of ways to consider adapting existing guidelines. Something that is a little bit distinct from adaptation is what guideline developers call contextualization. This particular study contextualized guidelines for chronic pain amongst those with musculoskeletal disorders for the South African context. And the methods are well described in the paper. The methods are organized in 4 broad areas. First, what they did was analyze locally, using qualitative methods, the enablers and barriers of managing chronic pain. They next did a systematic review to identify guidelines on this topic. They next considered, using consensus methods, how to contextualize the recommendations. And then they used both input from the expert panel as well as a stakeholder survey to further validate those contextualized recommendations. Now, this process was based on or borrowed from this particular study. Again, I know it's a weird slide, but this study aimed to contextualize guidelines for stroke and for low back pain for the Philippines. And again, it's this broadly 4-step process, but I'm showing you here a figure from that paper which nicely summarizes the sub-steps in each of those 4 broad areas. Another area receiving a lot of attention in the guidelines world is that of rapid guidelines, also referred to rapid advice, rapid responses, or rapid recommendations. And what I'm going to be showing you is a series of 3 studies that were related. In the first one, they wanted to find out what are rapid guidelines and how do you develop them. So they reviewed the methods used to develop 46 rapid guidelines. And the key finding of this study is that there was a lot of inconsistency in the methods and the reporting of those methods across those studies. So the next step was for them to interview some guideline developers who had developed rapid guidelines. Again, they used a variety of different processes, and the main point that this paper makes is that guidance is needed on how to develop rapid guidelines. So data from those 2 studies I've just showed you was then used to develop a rapid guideline development checklist. This was based on a pre-existing checklist of 146 different tasks organized in 18 domains, and the updated or more rapid checklist includes only 21 of those tasks or consideration. So definitely a more rapid process. Not unrelated to developing rapid guidelines is the idea of living guidelines, also referred to as living evidence, guidance, or recommendations. Unlike adapting guidelines and rapid guidelines, which are meant to reduce the time taken, reduce the number of resources needed, living guidelines are also meant to rapidly make available evidence and recommendations, but in fact, the resources required are rather considerable. This particular publication introduces the idea of living guidelines and makes that very point, that in fact to do this requires considerable resources and automated processes in order to continuously monitor for newly published evidence, to dynamically synthesize and present that evidence, and it also requires a very large pool of developers that can be called upon frequently and for rapid turnaround of decisions. A really good example of the application of this process is the COVID-19 Open Living Evidence Synthesis. So I've captured here a portion of that website in order to show you what it looks like. As you can see on the left of the screen, this resource now includes over 3,000 randomized controlled trials, many of them still recruiting, related to COVID-19 treatments, prevention, and vaccines. And this resource makes available 306 living syntheses, meaning data has been extracted from completed randomized controlled trials and added to a growing evidence base, again, on treatments, prevention, and vaccines. The availability of this data has enabled the development of living guidelines like this one, the World Health Organization Guideline on Drugs for COVID-19, which is published in a really easy to use visual format. And many more recommendations are available based on that data at this site, the COVID-19 Recommendations and Gateway to Contextualization. So this is a portal that can be searched either by keyword, or you can scan a full list of the recommendations or view a map of the recommendations based on topic of interest. And currently, on the day that I looked at it last, the resource includes 313 recommendations, over 1,100 good practice statements, and 839 additional guidance statements. So that concludes the end of my presentation. I realize this was a very quick overview of only a little bit of information, but about a lot of different resources. And I hope that in future, this may be useful to you in terms of innovations in health technology assessment. Thank you.
Hi everyone, my name is Tracy Merlin, and first of all I'd like to thank HTAi's International Scientific Program Committee for inviting me to speak today. I will be giving a perspective of the HTAi agencies and how they have innovated to deal with the HTAi landscape during the pandemic. But first, I would like you to imagine yourself as an explorer, and you want to get to this beautiful spot at the top or the peak of a hill. But the safety and stability of the bridge to get you there is uncertain. So you move carefully forward, you test the engineering in a number of ways, poking, prodding, and inching across before you get to the other side. This is a little like what we do in HTAi when assessing a technology. We test, we evaluate, we decide whether technology can get us safely and effectively to a position where we can produce better health outcomes for patients. However, poking, prodding, and inching across is not going to work in a situation like we found ourselves in 2020. And now, a position of urgency, and as a consequence, there was no time to poke, prod and test carefully before crossing this bridge. We had to make judgments incredibly rapidly about the safety and effectiveness of a technology or an intervention under extreme uncertainty. So this is what we knew, or should I say what we didn't know, early in the pandemic. And our response to this was quite wide-ranging. And some of these methods that we used were already in use and had been used in a limited way previously. The question is, do these responses or these methods have utility for general use when doing normal HTAi? And let's take each of these responses in turn. The first thing to note over the past 12 to 15 months was the immense amount of collaboration in HTAi. It occurred everywhere, but I'm just going to highlight a few. The COVID-19 Evidence Network to Support Decision Making, or COVID-END, was a time-limited network that was brought together more than 50 of the world's leading evidence synthesis, technology assessment and guideline development groups around the world. And they were addressing everything from public health measures and clinical management to health system arrangements and economic and social responses. That was from a global perspective. At the regional level, there was UNETA. Now, UNETA has been collaborating for a long time. It has spans 80 HTAi partners across Europe, but they took the decision last year to prioritise COVID-19 related initiatives above other work for the remaining duration of Joint Action 3. And locally, well, my local area is Australia, and in Australia we had the National COVID-19 Task Force, which was a collaboration of clinical groups, guideline developers, evidence synthesis and HTAi organisations, which developed living guidance on how to prevent infection, test for infection, and to treat patients with COVID. And collaboration between evidence synthesis organisations is a promising development and may reduce duplication of effort in the future. And I note that there are 2 panel presentations in this conference on developing synergies between HTAi and guideline organisations. And another innovation with collaboration was actually how we did it. We were using Zoom and Teams and collaborative platforms, working from home, but still working with each other. In terms of accelerated information gathering, there are a number of new databases created specifically to hold COVID-related literature. And some of these used AI, machine learning, and automated algorithms, as well as some human or manual curation of the records. I was curious as to how rapidly the evidence generation occurred and how it affected how evidence synthesis was done. So I went back and had a look at the monthly entry dates of literature on COVID-19 in PubMed from December 2019 until May 2021. And as you can see, the literature rapidly increased from February to May 2020 before essentially levelling off. When you break down the entries by evidence type, you can see that rapid reviews and scoping reviews were far outnumbered by systematic reviews. And on the face of it, this was really quite surprising because anecdotally, it was clear that many HTAi agencies had pivoted to doing ultra-rapid reviews. However, I think this comes down to the rapid reviews being mostly done systematically. And the rapid increase in systematic reviews follows the rapid increase of all literature, suggesting that these systematic reviews were being done quite quickly and probably because the evidence base was quite small at the time. Approaches were developed for conducting the evidence syntheses. The general approach was, first of all, to check that you weren't duplicating existing work. To update existing reviews if they were available. And if there was a need to do the systematic review rapidly, the methods often involved a narrowing of scope, parallelization of tasks, including having more people working on the evidence synthesis, abbreviated processes and the omission of some steps, and where possible, automation of screening or abstraction. Uncertainty is common in HTAi, if you just ask a health economist. But in 2020, it was taken to whole new levels. There was uncertainty brought about by the process of synthesizing evidence, as well as the uncertainty associated with the evidence itself. Evidence became available prior to peer review using these preprint servers, and early on, much of the evidence was of poor quality or based on expert opinion. As a consequence, we had to assess when it was more important to have a possibly accurate decision rather than a probably accurate decision, or to determine the trade-off in timeliness versus rigor. There have been examples over the past year or so of a loss of trust from policymakers when predictions, including modelled predictions, have been wrong. And therefore, a risk assessment might be needed to determine what the level of risk is for the policymaker in adopting the information that's provided in the HTAi. And our INATA panel later on in the conference will expand a little bit more on this. Value for money of treatments and vaccines was not really talked about, spoken of early on. HTAi, most people were interested in macroeconomics, you know, the impact on the whole of society, rather than the microeconomics. HTAi technology procurement processes became proactive from governments rather than reactive. They were actively looking to procure vaccines and treatments. So the value for money of competing technologies in terms of QALYs and ICEs was barely considered. One area where there was a great deal of growth was in disease modelling, whether it's dynamic or static, and there was a much better understanding and assessment of the impact of public health interventions and vaccines on disease spread. And this type of modelling gained a much greater acceptance by policymakers, and hopefully preparing us for the next outbreak, hopefully not a pandemic, and may have a payoff in future vaccine evaluation and evaluation of public health programs in the future. This is from the UNETA webpage and their COVID-19 response, and it demonstrates how the approach to doing HTAi subtly shifted. There was more collaboration, as I've stated, but and this is demonstrated with these rapid collaborative reviews, but it also became more of an iterative process. So as new evidence became available on COVID, whether it's treatment or vaccines or whatever, this information was incorporated in the reviews. So these ones were rolling collaborative reviews. Now, we've always done this type of updating in HTAi, but it's now it's become the norm. And this acceptance of a living HTAi has built on the preparatory work done previously for assessing technologies with an immature evidence base. The ways we've done it in the past is using real-world evidence to reassess a technology. We've created provisional registration pathways through the regulators for new technologies, and we've also increased the use of managed access and exit strategies. And we've seen this reflected in how new technologies have come in through the pandemic to treat COVID, a lot more provisional approaches, and with a view to looking at subsequent evidence to confirm the decision making. So does this mean that the definition of HTAi is no longer relevant? Well, no, because we already know that HTAi occurs across the technology life cycle. But I do think we might need to create a new definition for the concept of living HTAi. And as the chair of the English editorial board of the HTAi glossary with my other hat, I'll be suggesting to our board that we develop a formal definition for this concept, given how prevalent it has been over the last 12 to 15 months. But going forward, there needs to be a clear imperative for why reassessment in a living HTAi should occur. Could the evidence have been developed or gathered properly in the first place? That would be preferred because reassessment is resource and labour intensive, so you don't want to reassess unless you absolutely have to. If, however, you have a technology like this one, which is artificial intelligence being used with medical devices, then reassessment is reasonable because the technology changes quite rapidly, and it may even be required. HTAi organisations like HTAi in France are developing methods for evaluating AI, and we have seen recent innovations in HTAi methods, not just due to COVID, but also to deal with new technologies like CAR-T, tumour agnostic therapies, digital technologies, and genetic and genomic tests. In fact, talking about tests, COVID brought an awareness in health systems about how important it is to have accurate tests. And it's something that's done well in Australia. And last week, June 16th, new methodological guidance was released by the Medical Services Advisory Committee. And this incorporates a new framework for assessing these types of technologies, including how to assess gene panels using a facilitated approach, how to incorporate and demonstrate the concept of value of knowing in test evaluation, and how to assess special case technologies such as AI or static or dynamic algorithms, cascade testing for heritable conditions, and further information on codependent technologies. So thinking ahead with regard to HTAi methods, which of the responses over the last 12 to 15 months are likely to be maintained in the future? Well, I think it's possible to maintain the collaboration and information gathering, but whether the impetus will be sufficient to do this in other areas of HTAi is another question. Given the rigour and timeliness trade-off, I would suggest that these three responses would likely only be used in special circumstances. And I think that living HTAi and rolling adaptation of HTAi methods is here to stay, although greater thought will need to be given on when and how these methods are utilised. So I'll leave you with a quote. In Republic, Plato wrote, "Our need will be the real creator," which in turn became the English proverb, "Necessity is the mother of invention." Now, HTAi always invents and adapts its methods, but we've had a great deal of impetus to do this recently. Thank you.
Well, thank you, Martin, Anna and Tracy, for those pre-recorded talks. Absolutely fascinating, tons of stuff to pick up there. So Martin talking about innovation in randomized controlled trials, Anna talking about innovation in guidelines, and Tracy talking about innovation in HTAi, particularly dealing with uncertainty and modelling and the need for iterative processes as new evidence becomes available. So we're now into an open discussion and comment session. We've got a full 25 minutes, which is great because nothing irritates me more at virtual meetings or indeed live meetings than people saying, well, we've only got time for one burning question. Oh, what a waste of time, because all the learning and interaction happens during this particular session. So do pop your comments and questions in the button below on the grey zone there. It says live Q&A. Do pop them in there. Don't be afraid. We're all very nice people. And so feel relaxed. You can sometimes the simplest questions, or people say, well, I know this is a stupid question, but well, they never are. They're usually the best questions. So I'm going to start off, if I may, by asking Anna and Tracy a short answer to get them warmed up on a big question, because they've covered a lot of material. And that is, in your view, and I'll start with Anna, if I may. In your view, what is the one biggest opportunity for the future of HTAi that this particular pandemic has allowed us to reach for? And once you've mentioned it, what do you think the biggest barrier to us achieving that opportunity globally going forward? Anna.
Thank you so much, Hewell. And it was a very interesting panel. I really enjoyed the presentations by the other speakers. So I think the opportunity you highlighted, Hewell, in your opening comments, and it must be clear from each of the presentations that there has been an unprecedented level of collaboration and coordination to globally share and synthesize data and create rapid real-time guidance. There already was a high level of collaboration through both GIN and HTAi, both worldwide networks, but that was just ramped up so rapidly and to a far greater degree during this pandemic. So clearly it is possible. Clearly, people were already involved worldwide in both of those organizations. So the resources, the people are there. Automation is possible, clearly, because we've been able to gather and synthesize all that data quite rapidly. Healthcare is often behind the corporate world, the finance world in terms of automation, but I think that really ramped up. So clearly it's possible. The one barrier or challenge that I was thinking about in terms of sustaining this level of focused effort is the fact that COVID forced this very rapid and massive focus, but in some cases with unintended consequences. So, for example, by necessity, due to refocusing of healthcare resources, many patients have had to and are still waiting for delayed, canceled procedures. So it may be, even though COVID is still a lingering issue, we're not past it yet, it may be that there will be a need to refocus on the many other healthcare priorities in terms of research and clinical practice. So we'll need to see if this incredibly focused effort will indeed be sustained. But certainly the infrastructure, the processes have been laid down. And what's interesting to see is that there is this collaboration between GIN and HTAi. There's a session coming up in the conference where that working group, the GIN HTAi, will be speaking about the interactions and the collaboration that's been taking place. It will be very interesting to see if perhaps that level of focus and effort could be sustained through a very strong collaboration between those two groups.
Thanks, Anna. Before I bring in Tracy, just because this is a conversation, of course, the system shock of the pandemic, it's so sort of terrifying and tragic that the common ground for accelerating collaboration and cooperation has been unprecedented. So going forward, I mean, there may be other pandemics and catastrophes in the future that bring us together globally very quickly. But what about sort of more conventional large areas of healthcare, such as stroke and things? I mean, collaborations exist, but not to the sort of ramping up. Can you see, beyond COVID, this degree of collaboration still happening in other healthcare areas, Anna?
Again, I'll just emphasize a few points made that that clearly it's possible. Clearly there's a will. Now the infrastructure is there. Maybe in this session we can talk about what are the motivators, what are the factors that will sustain this level of collaboration. And as you've said, Huel, there are many other groups that could be brought into this collaboration. And how do we make that happen? I don't have
that's a good point.
Brilliant answers, but
the infrastructure's there.
That we should discuss.
I think you've said it, Anna. The infrastructure's there. How can we sort of jump on this opportunity now? So then over to Tracy. Biggest opportunity for the future, the HTAi, and once you've said it, what do you think the barrier is to prevent it sort of happening in the future, or realizing it globally as well? Tracy, over to you.
Thank you. And I can say that I did not share notes with Anna before starting this session, so I didn't know what she was going to say, and my answer is a little bit along the same lines. I suspect that the demarcation between HTAi and guideline development will blur further in the future, particularly as we continue to introduce technologies with an immature evidence base into the health system. So they're already being used, but they haven't yet had a formal assessment about whether or not they'll be publicly funded. And so as we do this sort of living HTAi, some of that, the role delineation will change a bit. So I think the biggest opportunity would be to continue on collaborating with other evidence synthesis organisations and guideline developers to reduce the duplication of effort and to identify and prioritise the conduct of specific evidence syntheses where there's a need. And this could be expanded further to consider the cost effectiveness of the technology to inform both policy and practice. We don't see a lot of the, with NICE being an exception, we don't see a lot of the guidelines where value for money is considered formally and modelling's done. So that might be a way to proceed in the future. Now, the biggest barrier to achieving this opportunity would be the methodological differences between evidence synthesis organisations. We all have different ways of working, even though there's a common, I think, a good common core sense of how we do evidence synthesis. But one of the other things I think where there might be a difference and which could be a barrier is the timeliness that's needed for HTAi compared with guideline development. Now, COVID was an unusual case where the urgency to produce the guidance was the same for both forms of evidence synthesis. The policymakers were learning about it at the same time as the health professionals. That may not be the case with some of our other technologies. So I think that might be the biggest barrier.
Thanks very much, Tracy. Over to Mindert.
Yeah, thanks very much both. And I'm going to keep an eye on the Q&A. And our first question is from Weija Oortwijn, new president of HTAi. Congratulations, Weija, of course. And you're asking us the following question. I'm going to read it out. Thank you for the interesting presentations. With regard to the second presentation, you mentioned the process for guideline development using consensus methods and then external validation through consultation. But I wondered if there are any general principles for deliberation used by guideline development committees, because I too realize that we talk a lot about getting the evidence to a certain stage, but how do decision makers then use this collaborative nature of the evidence that we developed? So a very pertinent question from Weija. Shall I, Anna, I think you're probably the first to have a go at this.
Thank you for that really relevant question. That, I believe, is rather a gap in our the processes that we have, which are consensus oriented. So how do we use discussion, deliberation, and even consensus of guideline panels, HTAi panels, but translate that into guidance or insight that can inform actual policy and practice. While we have a variety of different consensus methods, they really focus on establishing the level of agreement, the consensus between panelists, and not necessarily on how others are to interpret that consensus, to integrate it with existing qualitative or quantitative evidence or other forms of knowledge like experiential knowledge. I don't know, I'm certainly no expert, but I don't know that we have guidance on how to translate consensus and support decision making. That's probably would be a fantastic area of research to focus on that would give someone interested in a lifetime career of research, and certainly very needed. Thank you for the question. I don't think I've answered it very well, but maybe others
No.
can add some information.
And I also thought, because Tracy mentions risk and risk assessment as one of the areas of interest, and I wondered myself where we translate our appetite for risk. We've heard this morning from June Rain about the regulatory appetite for risk, from a policeman to an enabler of innovation. We've heard Martin talk about his appetite for risk in the context of a trial, an adaptive trial, guidelines, taking more risks. How do we bring together these various perspectives into one decision maker? That's I think behind the question why I asked. Probably very difficult.
Right. So something that we may want to study in real time is, now that we have rapid HTAi, rapid guidelines are now available, how are the policymakers using, how are the decision makers, clinical decision makers, policymakers using these rapid forms of evidence, and what other issues or factors or considerations are they combining with these rapid forms of evidence to actually make real-time decisions as you know, the evidence is becoming available day by day, week by week during this pandemic. So lots and lots for researchers to study.
It will also depend on the tolerance for risk in the community as well. So as long as the technologies are being introduced and they are performing and doing well, that's great. The problem is when we get additional information later on, and an example for that in Australia would be, well, around the world would be about the vaccine AstraZeneca and the clotting TTS issue, and how that's had an impact on, because the information has been changing as we've been going, and how well then the impact it has on society, and how well the technologies are therefore accepted. So it is a really interesting space, this risk assessment, and I think there might need to be clearer signposts for policymakers, at least, about how the evidence synthesis has been done and what the possible gaps are. But if we're going to go with this living HTAi approach more generally, apart from COVID, then there will be risks faced by governments, and also in the pricing as well of the technologies, and risk sometimes results in a lower price to industry and to the companies, and that might be a way that it's more palatable for the payers.
Hal, have you found?
Yes. No, we've got tons of questions coming in. Really good questions. So thank you very much for interacting. I've got a question from Helen Knight here, which I can relate to, and I'd like to ask the panelists. So Helen is asking, what are the panel's thoughts on the resource implications of iterative HTAi, and how do you balance this with the many technologies requiring HTAi? I can certainly sympathize with that as a funder of primary research. It's all very well creating an ecosystem just for one important condition, but That's 300 more. So, so what are your thoughts about the resource implications? Well, who would like to answer that first, Tracy or Anna? Tracy, go ahead, and then Anna. Okay, go ahead.
I'll have a go first. Yeah. I have thought about this. It is potentially quite problematic. And that's why I said in my talk that we need to think about when is it absolutely necessary that we do a living HTAi, and when do we just wait for the evidence to be generated the way it normally would be. I have some concerns that that, you know, it might be seen as an easy way to get a technology in if you're not running the full trial and you're just providing it on a very immature evidence base. But if we've got, you know, hundreds of technologies in that sort of position, it will stretch the HTAi resources quite considerably. So I think we need to, as a community, develop guidance or principles about when these immature technologies, these new technologies coming in with a very, I'm mostly familiar with the cancer drugs and cancer therapies where this is happening, but we need some principles about when is it sufficient to provide, when is it reasonable to provide immature evidence and use the living HTAi process, and when is it not. You know, if you've got a very common condition, easy to enroll people into trials, then there's no reason why you can't do it the way we always have done.
Thanks, Tracy. Anna, did you want to come in on that? Or you don't have to, but if you have a view on it, you're very welcome.
I think Tracy did a lovely job of answering that question.
Great, thanks. Over to you, Minded.
Yeah, okay, Anna, here's one for you then. Dalia Dawood asked the following question, and I think that's a very interesting point he's making. Does encouraging adaptation and contextualization, which is, you know, obviously very good ideas, and adapt, contextualize, does that reduce actually the potential for low and middle income countries to invest in developing their own expertise and training? So could that be a unwanted consequence of this adaptation and adoption?
Not something I've given a lot of thought to previous to this question. It seems like that's where in the low middle income countries, it seems that is where the adoption, adaptation, and contextualization is taking place. It seems to me that even those processes that are meant to make development or adaptation more rapid and to reduce the time and resources needed, it seems that there are many parallels in the adaptation contextualization process with guideline development or HTAi development. So I don't know that expertise and skill and knowledge will be reduced. In fact, I think it will be expanded. If we look at the contextualization process, it requires not only parallels with guideline or HTAi development, but even a further expanded analysis of what are the enablers and barriers, and then incorporating those considerations into development. So it not only potentially requires a greater number of individuals on the HTAi or guideline panel with differing expertise, but really expands the knowledge needed, but also the knowledge going into the development of either guidelines or HTAi.
So I'll press on with the next question. So just to refer to Ayla Lockhurst, you asked a question, Ayla, about consent from patients. Sure that consent of patients was, and but I can't answer it authoritatively without Martin being here. So do have a look at the recovery website, because I'm pretty sure it's clearly described then. I'm sorry I can't address your question more fully than that. So if I could turn to a question here, a lot of people think it's rather important, and it's from, sorry, I'm scrolling away here. I think it was, bear with me. Yeah, here we are. So this is a question from Wim Gertsch, and saying Anna refers so much to grade in her presentation. Oh, sorry, it's just disappeared again. I'm sorry, just when you get some message coming in, where your sort of place in the scheme disappears.
Maybe someone can bring it back.
Can you see the question?
I found it, Hal.
Tracy, thank you. Could you read the question out, Tracy? Could you do my job? Could you do my job for me and answer the question, please? Thank you.
Well, I'll refer it to Anna, because it's us, Anna first. As Anna refers so much to grade in her presentation. However, we know from practical experiences in Europe and research that we performed that the willingness of HTAi to use grade is still restricted to a few agencies. Is this something that would impact further interaction between HTAi organisations and clinical guideline developers?
So I'm not, in the past, I have developed guidelines. That was before grade existed. I'm of the age where grade would be something rather new to me, because I developed guidelines a long time ago. So I can't comment on the relevance of grade to HTAi development. But what I've been really interested to hear about, and again, I echo Tracy's earlier comment that she and I, didn't compare our presentations or notes in advance of this, but I was very interested to see so many parallels, and very interested to see that the GIN HTAi collaborative working group is presenting at this session. So I think that's really, really promising in terms of being able to share information about what works, what doesn't work, what needs to be simplified, what processes need to be improved, what processes or infrastructure or tools or other supports are not available now that are needed. So it may well be that the grade is not terribly relevant to HTAi, but hopefully through ongoing sustained collaboration that we've been referring to throughout the session, issues like that could be resolved.
I can add a point there too.
Yes, go ahead, Tracy.
I had a student do a project on looking at how commonly grade is used in HTAi and also guidelines. And I think, and Vim was right that it's like a lot less in HTAi. I think it's about a third of HTAs in the sample we looked at, and it was between 50 and 60% in guidelines. So still not widely prevalent, but certainly more than what's in HTAi. I think there are a number of principles that are the same in grade as well as in other ways of appraising evidence. And I think that there's commonality on those. So you don't necessarily have to go through the whole grading process, but the issues of looking at risk of bias and looking at how confident you are in the estimates and that sort of thing is pretty much common across evidence synthesis, irrespective of whether it's HTAs or guideline developers. So there is some common ground there. I did say that there might be methodological differences, and that would be a barrier, but I think it hasn't been a barrier so far with what's happened with COVID. So, maybe there's some lessons learned there. Maybe the people that have worked together in those collaborations can share with us how they surmounted those methodological differences to try and work together.
Thank you. I'm going to ask just one more question, and then I'm going to hand over to Minder to sum up with his reflections. But I've just seen a question coming in from Jyotsna Naik. Greetings from India. Welcome, Jyotsna. And Jyotsna wanted to know if a clinical trial is run in parallel to a HTAi study, which requires a clinical trial and there's a lack of evidence. Are you aware of any such studies being run in parallel by the HTAi agency in any country? And I think this is relevant, you see, because Martin is missing from this conversation, and I've heard a lot of collaboration between evidence synthesis and guidelines, but not that connection with the primary research cycle, which was what paper one of Philippe Bravo's series was about. So that seems to be the missing bit at the moment, this connection with primary research. Who would like to respond to that?
I wonder if Tracy's better placed to answer
Okay,
that.
yeah, go ahead then, Tracy.
I can give it a go.
Give a short answer because we want some
a short answer.
Yeah,
I think may not be parallel, but certainly informed. So you do the evidence synthesis first to find your gaps and the areas that need an answer through the primary research, which I think is what happens in the UK anyway.
Yeah.
And then that gets answered, and there may be a meta-analysis done on prior research, and as soon as those findings from that new trial comes in, then they can be incorporated into the HTAi. So I think it's possible to do, may not be exactly parallel, but certainly talking to each other.
Yeah, certainly a cycle there, beautifully summarized. Thank you, Tracy and Anna. I'm now going to hand over to Minded, but I'd like to thank, well, all three speakers, Martin as well in his absence, but particularly Anna and Tracy. Over to you, Minded.
Well, and thank you, Howell. You're a master at running these sessions, and thank you very much for your support in all we've done, and thank you to the speakers and to HTAi for making this session available to all of us, and for the ISPC for selecting the topic. And I should call out Dalia Dawood, who asked a question but has been behind the scenes working very hard on this session. What a great kickoff to the annual meeting. 3 excellent contributions. From the length and breadth of the evidence ecosystem, I would say. It's clear from what they have told us, and I'm very much learning still, even after 17 years at NICE, that this is all about collaboration, isn't it? Leadership and trust. HTAi is a people's business. HTAi is a people conference. HTAi is about social connections. It's such a shame that we have to do this via Zoom and all our digital ways, because I think we could have gone on and on to talk about this topic in our lunch breaks and coffees. Living HTAi are all about developing rapid, robust and responsive recommendations, we've heard Tracy say, to support improvements in health and well-being for the people we serve. And we haven't really talked a lot about patients in this session, but it would have been an absolutely important question to address. How do patients involve themselves in these collaborations? Can they make them happen? Would that not be the way to do it all? We'll have to think very differently, in my mind, about collaboration, risk, resources, and review. This is about culture. This is about skills. This is about new people into our world of HTAi. I think our old hats are probably soon out of the game because automation, digitalization means new ideas, new skills, new culture. So I think if we invest in all of that, we will come out of this pandemic with a new spirit of HTAi, be it called living or whatever else we might think of, and we'll be much better connected. So I thank you very much for listening to today's opening remarks by our various speakers, and wish you an amazing conference. I hope to see you around somewhere in the digital space. Thanks, Howell. Bye-bye. Oh, that was the end. Thanks very much.